Wasn't even anything. It was literally just like we gotta get moving here. That's cool. Wait, bro. Yeah, bro.
Good morning, good morning, good morning. Okay, friends, it is time to start. So we had the outage last night. I checked Blackboard and sure enough, there were some grades missing after the outage. So I tried to put as many back in as I possibly could. Between you and me and that wall, I'm getting pretty sick and tired of this. You have to enter grades 2, 3, 4 times. So if you see discrepancies between what you know to be true, some of you have given me some things to let me put some in. Please let me know. However, let me know this week. Let me say that again. Let me know this week. Do not contact me in the summer and say you forgot to give me focus series points. I will tell you to go pound sand. Seriously. Deal with it now. Don't come to me over the summer and say, please deal with this. The time to deal with this is now. Now, this week. Don't do that to me. I've had more than enough students do that to me. Now, let me just tell you, it's irritating. It's extremely irritating. Because I will tell you, what did I say? You'll say, well, I don't know, I wasn't listening. Which I'll say, tough, because I'm not going to tell you what I said. So deal with it now. I will not deal with it over the summer. Summer is time to recharge, not to deal with stuff that you didn't deal with during the semester. So having said that, outages tend to just drop grades out of the tree, which is irritating, but it happens. All right, so this is our last time together before the final. Don't forget, Tuesday, we have a review session. That will be in Whiteman-Gibbs 103. Whiteman-Gibbs 103. I think we said 7 o'clock, was it? Is that when we said? Well, that's what I'm saying now, 7 o'clock. That is a Tuesday. The exam is Thursday, bright and early, just like this class. The guys should be all ready. Huh? Oh, okay. Yes, it is. It is. So my daughter got back from Greenville. They finished because they started in the middle of January. And then she said hi. She went to church. We had lunch, and then she toddled on upstairs and went to bed. Proceeded to sleep for 14 hours. So she spent the whole week basically doing 2 hours of sleep or something like that. So that's the whole finals week thing. I get it. So my response was, sleep, dear girl. I won't wake you up. Then she got up this morning and went straight to the coffee machine. Life of a student doesn't really change during the summer, does it? All right, so we're talking about insulin. We will get through this probably. We'll maybe just start osteoporosis. We'll see how far we get. Okay. Insulin is given by injection. It's injected subcutaneously. You never inject insulin intramuscularly, never. You can give insulin intravenously, but you typically will give it subcutaneously. The sub-Q area of the skin is very rich in blood vessels. Those blood vessels will absorb insulin, but here's the trick about insulin. Insulin aggregates into groups of 6. Those groups of 6 hexamers are too big to be absorbed. So those hexamers need to dissociate into monomers. Then they get absorbed. That's the reason why regular insulin peaks at 2 hours. You don't really get much activity from regular insulin until about an hour and a half later. So rapid acting insulins are genetically engineered not to form hexamers. They form monomers. So when they get injected, they get absorbed. That's why they will peak early. They'll usually peak 1 hour after injection. You first start getting activity usually about 30 minutes. So the diabetic has to inject themselves at least 30 minutes before they're going to eat, because if they eat, there's no insulin there yet, because it needs to take time to be absorbed and what have you. So there is a new insulin. This is called Lumjev, L-Y-U-M-J-E-V, but it's pronounced Lumjev. This is a Humalog insulin. But it is formulated with sodium citrate. So the sodium citrate will improve vascular permeability. Then it's also formulated with a prostaglandin. Spell this right. Treprostinil. Treprostinil causes vasodilation. This stuff, therefore, gets absorbed a lot faster because it goes in and it makes the vessels more permeable, then it gets absorbed. So this will start getting absorbed after 15 minutes. So this stuff is really fast. This was FDA approved 2017, and it was made available for pumps in 2020, late last year, essentially. There. That way I don't trip over you anymore. Now, insulin comes, as you remember from the handout I gave you, insulin comes in rapid acting, regular insulin, intermediate insulin, And the intermediate insulin, it's usually called humulin N, or it's called NPH, neutral protamine hagedorn. This is insulin that is bound to a protamine salt. So when you inject it, it has to dissociate from the protamine salt. Then the hexamers need to dissociate, then it gets absorbed. So this insulin will peak about 8 hours. That's the average time that that will peak. And it'll start to act usually about 4 hours later. But the peak is 4 hours. This insulin, you can usually tell because it's cloudy. The other insulins are clear, or at least they should be clear. In fact, before you administer insulin, one of the things you're supposed to do is look at the vial. If it's not clear, it's contaminated, don't give it. But this insulin, intermediate insulin, is cloudy. Now, when you administer NPH, you never do this. Why? Why don't you do that? Bubbles. Bubbles are your enemy. So how do you mix it? You mix it like this. You roll it between your hands like this. Then you draw your insulin. So that one you need to mix. You never give insulin a shake. You'll foam it, you'll get bubbles in it. Never. Sometimes physicians will order 2 different types of insulin. Do you want to stick people once or twice? Yeah, Sarah's sitting there. Once, please, just once. Yeah, just once. Well, let me just put it this way. Do you want to get a needle stuck in you once or twice? Yeah, once. So in that case, you will mix insulins. Now, when you're mixing insulins, usually the doctor will order regular and intermediate insulin. That's usually what gets ordered. When you mix insulins, you always go from clear to cloudy. Clear to cloudy. And the stupid mnemonic I have to remember that is you will go from regular insulin, which is almost always called humulin R, to the intermediate insulin, which is usually called humulin N. So remember the nurse who will give you the shot, the RN, you go from R to N. Or clear to cloudy, whichever helps you remember it, that's fine. Diabetics should never mix their own insulin. Never. Now, the long-acting insulins. The long-acting insulins are peakless. They're genetically engineered so that they just get absorbed at a very, very, very slow rate. Oh, that's better. Much better. So the one that is most commonly used is called mellitus. Mellitus is the trade name for insulin glargine. So this forms little microcrystals. You inject it, forms crystals. Then those crystals they form in a pH-dependent manner. As the pH changes, the crystals very slowly dissolve. And they very slowly release insulin into your system. So they're peakless, they're baseline insulin. In the hospital, you never mix Lantus with anything else. You give Lantus by itself because that mixture is pH dependent. If you mix it with anything else, you're going to cock up the pH. You cock up the pH, it won't work anymore. So you can mix regular insulin with other stuff. Don't mix mellitus with anything. That stays by itself. Insulin, as we said, will induce cells to take up glucose. They'll induce the formation of glycogen, synthesis of protein and muscle, synthesis of fat. And because of that, one of the side effects of insulin injection is this phenomenon called lipohypertrophy. Lipohypertrophy. So if you inject insulin someplace, you're going to get fat forming there. And that fat will, after a while, when you withdraw the needle, it'll shrink. But then when you feel the tissue, it feels like there's sand underneath your skin. That's lipohypertrophy. So how do you fix that? You rotate your injection sites. And again, remember our rules for SC injection. You inject, remember 1 inch from, 2 inches from, and you never rub it after you inject it, and you always rotate sites. Those are our 4 rules of sub-Q injection. Now, insulin used to come from the pancreases of cows and pigs. Not anymore. I don't even think the animal products are sold anymore. It's all genetically engineered now. Now, think through this with me, would you? So, what makes insulin a genetically engineered organism? Do you have a problem injecting that into your body, any of you? Yet how come we get all torn up about genetically engineered food? Would someone please explain that to me? Yeah, we're a little schizophrenic when it comes to genetically engineered organisms. More and more, we're seeing no GMOs on the back of products. And now people in Congress want there to be special labeling for genetically modified foods. Yet we have no problem with genetically modified organisms making our medicines. If someone can explain that to me, please, because I don't get it. Insulin is used for diabetes. It's also used to treat hyperkalemia. Can anybody guess why it might be used to treat hyperkalemia? No, not necessarily adipose tissue alone. Sodium potassium ATPase, its activity is increased by insulin because insulin causes glucose to go into cells. Cells use it to make ATP. More ATP means this pump is increased, so you pump more potassium into cells. Because you pump more potassium into cells, you decrease serum potassium levels. So it's also used to treat hyperkalemia because the sodium potassium ATPase pump is increased. Okay, so our rapid acting insulins are the only insulins used in pumps. The regular insulin sometimes gets called short acting. So this will usually peak about 2 hours. It will last, its activity lasts about 4 hours. You can see the rapid acting insulin doesn't really last very long. Usually lasts 2 hours or so, 2.5 tops. Because it will act rapidly, that's why it's so good for pumps. There are 2 main rapid acting insulins. However, their formulations differ. So the kind of old pro is the Lispro. That's the one that was made by Eli Lilly Corporation years ago, and it was made by mistake. It was a cloning mistake. And they said, well, it's a mistake, but we'll keep it on. And they discovered that it worked really fast, but it has short half-life. They said, gosh, when would something like this be useful? Yeah, you need to keep your mistakes sometimes. Then Aspart was designed by Sanofi. It was called Sanofi Aventis at the time. Now it's just called Sanofi Corporation. That's also rapid acting, and then these have different formulations. And some of those formulations are on your handout where you have bioidenticals that are cheaper, and they all work quite rapidly. Regular insulin is being used less and less by diabetics just because the rapid now is being used in pumps. People get better control with pumps. So you're getting more and more diabetics being transitioned onto pumps. And it essentially works, takes a longer time to work, has a longer period of activity, but it's just being used less and less. The intermediate insulin is being used more by type 2 diabetics. Also, you have mixtures of intermediate insulin with regular insulin. Those are shown on your list at the bottom where it says mixed insulins. So you have mixes with intermediate and regular insulin and so on and so forth. 70-30, 30-70, stuff like that. Again, that's used mainly for type 2 diabetics. You can see the NPH, it has a very modest peak and then is spread out. And this is good during the day just to give you control. When the rapid insulin stops working, the intermediate insulin now kicks in and it can actually control the blood sugar after the rapid acting insulin has stopped working. That's usually what it's used for. And then Lantus and other insulins like it are peakless. They're used essentially for baseline. You essentially give yourself a shot at bedtime. And then this shows you the difference between the two, whereas the intermediate will peak and go up like this. The Lantus is just slow and steady, wins the race, and it lasts for a whole day. Insulin detamir. This is a different type of insulin than Lantus. So detamir has a lipid group attached to it, so it binds to serum albumin. So it gets absorbed, and then it finds these blood proteins that only give it up very slowly. So this insulin can actually last a little bit longer than 24 hours. And then now there is another insulin called Triceba or Degludic. This stuff can last for 3 to 4 days. This again has a molecular modification. It has lipid groups attached to it. It goes in, it binds serum proteins, and it gets released at a very gradual rate. So it gives you a nice baseline for several days. This stuff is new, so it's kind of expensive. But for people who only want to give themselves one shot every several days, this might be your drug of choice. When you have a kid who's a type 1 diabetic, they're going to go to bed, and when they go to sleep, their pituitary is going to release growth hormone. Growth hormone tells cells, don't take up glucose, take up amino acids. And so cells incorporate amino acids, and you start to build protein, and you start to build bone, and things like that. But glucose gets left out in the cold. So what's going to happen to their blood sugar during the night? It's going to climb, even though they're not eating. That's called the dawn phenomenon. You see that most acutely in children. As people get older, what happens to growth hormone secretion levels? Tanks, goes down. So does this become as much of an issue in older people? The answer is no. The answer is no. So the dawn phenomenon is more common in kids. And so you treat this by giving a dose of insulin before they go to bed. Now, there's another effect you see in adults, though. It's called the Somogyi effect. In this case, the blood sugar does this. Now, as it gets down here, your pancreas releases glucagon. And then the blood sugar is going to go. So you went to bed, maybe you were 100, 120. You wake up, you're 200. You're thinking, what the hey? I didn't eat anything. That's the Somogyi effect. It's a response to a nocturnal hypoglycemia. So if you give a nighttime dose of either intermediate insulin or mellitus, that can actually fix this. So you have to give yourself a shot usually before you go to bed. Another issue I had forgotten to mention, your secretion of cortisol peaks during the morning. Cortisol, you will remember, is going to take small molecules and it's going to tell the liver to convert them into sugar so that you have energy for the morning. It will get those small molecules from muscle. So did your mother ever tell you that breakfast was the most important meal of the day? In honor of Mother's Day, let's just pause and remember Mom was right. Because in the morning, you make cortisol. You don't eat, you do gluconeogenesis. Where do you get those small molecules from? Muscle. So in the morning, if you don't eat, you're going to lose muscle mass. So your mom was right. Breakfast is very important Okay, Amanda, you're looking at me skeptically. Your mother was right. If you want to keep that muscle mass you've worked so hard to make, eat breakfast. Eat breakfast, because otherwise gluconeogenesis is going to take from Peter to give to Paul. Peter being skeletal muscle to give to Paul, that is your liver. And this morning cortisol release can contribute to the dawn phenomenon, particularly in children. So insulin is measured in units. How much do you give yourself? That depends. We're going to look at this, but people will have a so-called insulin to sugar ratio. A certain amount of insulin will cause their blood sugar to decrease by a certain amount. That's different from person to person. A diabetic will usually know their insulin to sugar ratio. If you use a injector, insulin more and more now comes in an injector pen. So you self-inject using an injector pen. And the pen usually has a knob on top. You adjust the amounts of insulin, and then you just pinch and give. You again, rotate sites where you give the insulin. And you need to give insulin on a schedule. If you have a pumps, the thing about pumps, you need to switch sites and your tubing. Your tubing can grow things. Make sure you use fresh tubing at least every 3 days. If you have a constant glucose monitor, you rotate that. That has to be switched out every 10 days. Rotate that every 10 days. Rotate insulin sites every 3 days. Otherwise, you get this lipohypertrophy, and you're going to get a big fat pad. That's going to prevent insulin from being absorbed. There is an entire industry in medicine called diabetes education. Some of you who will work in healthcare will do a lot of diabetes education anyway, because you get patients who are not well managed and they need a little bit of education. So those of you who want to be PTs or OTs or even be PAs or nurses or doctors, you'll do a lot of education. So it's incumbent upon you to figure out ways to explain this to people, to keep them engaged, to put the cookies on a nice low shelf so that the patient can understand it. But one of the things that patients will need to do is learn how to self-monitor using a glucometer or using a constant glucose monitor. Constant glucose monitors will usually send signals to a detector, which more and more is now in your cell phone. So there are programs now, apps on phones that will tell you your glucose readout. There's two products, Dexcom and Medtronic. And Dexcom is probably more user-friendly. Medtronic has a big part of the market. Problem with Medtronic is it's very medical looking. So it looks a little more intrusive, whereas Dexcom is a little less scary looking. They need to know the signs of low and high blood glucose. And they need to be able to do something about it. Type 1 diabetics need to have snacks with them all the time. And if you go to places like Cedar Point or Disneyland or Universal Studios, they may say, well, you can't bring bags in with you with snacks, except if you're a type 1 diabetic, because that's a medical product that you have to have. And so usually what you do is you go there with a type 1 diabetic, you put your snacks in their bag, and then you have your snacks with you. Okay, but all things considered equal, they have to always keep snacks with them, because if their blood sugar gets low, they need to be able to take juice or glucose tablets or whatever. They need to know the signs of high blood glucose and be able to treat it properly. And they need to be able to know how to monitor blood glucose with a glucometer. They need some sort of medical alert. You can wear a medical alert bracelet, or you can have it tattooed on the inside of your wrist. And EMTs will know to look for that if you have a medical emergency. Then there are classes you can take. Some of you may end up teaching those classes in your medical career. I hope some of you do, because those classes can really save people's lives. Diet is huge for diabetics. You have to count carbs. Counting carbs is an art form, and many diabetics can just look at food and tell you how many carbs are in it, guesstimate-wise. Oh, that's 30, that's 40, that's 50, oh, that's 80, so on and so forth. Learning how to do that is something that you'll need to just be able to do and do quickly. And then you need to make sure you give yourself insulin that is appropriate for the amount of carbs you've eaten. You also need enough protein and fat in the diet to be able to accommodate your dietary needs. So diet is really big. Insulin can be stored in the refrigerator, but if you pull it out, it's good for a month. If it starts to get cloudy, unless it's NPH, which is already cloudy, it's no good. Throw it out. May not work, or it may be contaminated, and you may be injecting yourself and giving yourself cellulitis, which we can agree is not good. So if it's cloudy, if it has precipitates in it, pitch it, unless it's NPH, because NPH already has precipitates in it. Oh, when your patient pulls insulin out of the fridge, warm it up, because if you inject cold insulin, that's going to sting. It's going to really sting. Trust me. So warm it up. Do the again. Don't no. Don't shake it. Never shake your insulin. Swirl it. Swirl it. Swirl. Okay. You know, give it the old stiff arm. Something like that. Swirl it like a martini. Okay, I didn't say that. Swirl it like a nice Mountain Dew, nice bouquet. That way, you need to see the particulates, but don't ever shake insulin. Don't shake it. And then warm it up. Just give it the old between the hand thing. Same thing with pumps. Just cold insulin, it will sting. You rotate sites of injection. Now, I'll be the first to admit that trying to reach parts like this here on your back can be pretty near impossible unless you're a gymnast. But in that case, you might have someone inject it for you. So get a healthcare provider to inject it for you. But the important thing is to make sure you're rotating sites of injection. Again, I keep reading on the web that injection into various sites will cause you to lose muscle mass. That's bull. Why? Because you're not injecting into the muscle mass. You're injecting sub-Q. So don't be afraid of injecting into the arm, because you're not injecting IM. If you are, you're doing it incorrectly. And again, I can't emphasize enough, know the signs of hypoglycemia. The biggest side effect of insulin for type 2 diabetics is weight gain, but the other for type 1, it's hypoglycemia. So just that cold, clammy, confused, tachycardic, those are all things to consider if someone has early signs of hypoglycemia. Insulin will cause hypoglycemia. That's the biggest downside of insulin. So two very, very large studies showed that the tighter your glucose control, the lower your risk for complications. So the United Kingdom Prospective Diabetes Study Group, this study group is continuing. This has thousands of people in this group, and they showed, again, the tighter your control, the lower your risk for all kinds of complications. In the US, the DCCT, the Diabetes Control and Complications Trial. This is a 10-year prospective trial. It's still ongoing, but the data concurs with that of the UK study. The risk of complications goes down the tighter your control. So here's a pump. Pumps keep getting smaller and smaller. So the old pumps were this size. The new pumps are about this size. They keep getting smaller and smaller, and they just have a little pad. You have a needle that goes into the sub-Q, and it delivers insulin on a regular basis. And now, because this is keyed in with the CGM, the pump will adjust itself for your glucose rises and drops. It's remarkable, just remarkable, the automation of these. And then again, this is tied into Dexcom. This is Dexcom, which goes to your phone, gives you a consistent, constant readout of your blood glucose, and you can very fine tune your insulin. You still have to program in meals. You program in how many grams of carbs you're going to eat, and then the pump will deliver based on your settings how much insulin you're going to need. You don't have to do any calculations anymore. Now, one year when I showed this slide, a student burst out laughing, monitor BS. They said, what, am I supposed to be on Twitter? Which is full of BS. No, BS in this case means blood sugar. Blood sugar. So monitor blood sugar, monitor it regularly. And if you have a constant glucose monitor, that's easy. Otherwise, make sure they are pricking their finger, monitoring it at least 5 to 6 times a day. Have a regular meal schedule. Report weight changes regularly. If you change weight, that may change your insulin dose. You also need to know, unfortunately, this day and age, about the patient's insurance. What will the patient's insurance pay for? What won't it pay for? Being a diabetic is a very expensive venture. Some insurances will pay for everything. They'll pay for the glucose monitor, they'll pay for pumps, they'll pay for Dexcom, they'll pay for whatever. Others won't. So there are stories about diabetics who don't buy groceries because they need to buy insulin. I believe those stories. And part of it is that because it's been very hard for companies to get generics licensed, so generics will bring down the price of insulin. Insulin prices have continued to climb because the companies don't have any competition, so they could raise prices as high as they want, thinking insurance will pay for it. And 999 times out of 1,000, that's exactly what happens. But for those who don't have insurance, they're the ones who get the shaft. So in cases like this, we need competition. And frankly, why can't we just have type 1 diabetics just all be on Medicare and then Medicare pay for their stuff? That would cost the government peanuts. frankly, compared to what we pay on Medicare. If you subtract all their trips to the hospital for complications because they don't get insulin, I'll bet you paying for their insulin and stuff like that, I'll bet you'd be money ahead. I'm not an economist, so I can't say that for sure, but that's my best guess. So, but again, nobody cares what I think because I'm a nobody. But you might want to D there, just think, no patient's insurance, make sure the patient knows their insurance and what their insurance will pay for. Now, some pharmacies, there's a pharmacy, for example, in Wyandotte, who will stockpile samples of insulins and things like that, and will give them to patients out the back door. That's completely legal. So when the sales rep comes by, she'll say, she'll just be really skeptical. Oh, I don't believe that works. So she'll get tons of samples because they'll say, oh, we'll try them out. She'll say, okay, I'll try them out, but this doesn't work. You're going to hear from me. And then she just shovels them out the back door to people without insurance. So occasionally you'll find pharmacies that will actually serve people. And then some drug reps actually know they're doing that, and they'll just leave them a ton of samples anyway. So there are ways sometimes for people to get, it shouldn't have to happen that way. It shouldn't have. I'm glad pharmacists will do that. I'm glad drug reps will do that, but it shouldn't have to happen that way. That's my opinion, but again, nobody cares what I think. So evaluation, blood sugar, is it controlled? That's a sine qua non. Is their blood sugar controlled? If their blood sugar is controlled, they're not going to have complications. And the long-term check on that is their hemoglobin A1C, or if they have a CGM, the graph essentially of their glucose levels. And then is the patient satisfied? Does the patient have energy? Are they relatively free from the quibbles of diabetes? Are they able to do the things they like to do? Do they have energy? So on and so forth. Type 1 diabetics will have a little kit with them. The kit is usually a zipper thing. You get them at these conferences or meetings or classes. Some of them are not much bigger than this, but they will have in them usually snacks. So they'll have snacks to eat. There's usually this goo. It's disgusting. Or they'll have little glucose tablets. But the other thing they'll have will be an orange container, and it will be a glucagon shot. Now, if somebody's blood sugar gets so low that they pass out, then you open this, and there's a picture that shows you what to do. You take the glucagon, you draw it up in the syringe, you pull it out, and you give it in the biggest muscle you can find, which is your quad. You jam it in the quad, you give them the shot, you get over your queasiness and your fear of needles, and you do what you have to do to save that person's life. They will wake up. They will typically puke because the liver now has dumped all its glycogen. This gives them enough energy to get a snack and get a meal. They're still not out of the woods, but they're awake. If you do this and they don't wake up, you better get an ambulance there ASAP. Also, put a little honey underneath the tongue. Do not give them an insulin shot. What's an insulin shot going to do? It's going to lower their blood sugar even more. You'll kill them. That's precisely what happened to some friends of my brother's when he was in college. They went hiking. He didn't take snacks. They got, he was starting to get a little goofy, so on and so forth. He passes out on the trail. Now, what did his friends do? They cared about him, so they wanted to do something. They gave him a shot of insulin. It killed him. Now, were my brother's friends, did they have good intention? Yes. What killed that kid? Ignorance. Ignorance killed that kid. Don't be ignorant. Don't be the ignorant one. They should have given him a shot of, say its name, glucagon. It's in the orange container. Now, there's a new glucagon that just got released end of last year. It's called Gvoke. You don't have to draw it up. It just comes as a syringe. You just take it and jab it. And then there's another product now called Baqsimi. That sounds Arab, doesn't it? Baqsimi, Baqsimi. This is a nasal powder. You stick it, you've seen it? No, it's a nasal powder. So they snort it, essentially, and it works really fast because the nose is full of blood vessels. So if you open this and it's a powder that you blow into the nose, put it in the nose, blow it in there, just like you would Narcan for an heroin overdose. All right, so the major complications of diabetes: hypoglycemia, diabetic ketoacidosis, hypoglycemic non-ketotic coma. That's if the blood glucose gets way high. And then, of course, the chronic complications due to damage wrought by all that sugar. Let's rehearse them: diabetic vascularitis, diabetic cardiopathy, myocardiopathy, diabetic neuropathy, diabetic nephropathy, and diabetic retinopathy. Again, if someone's diabetes is well controlled, you can greatly reduce the effects of complications. But it needs to be controlled. That takes discipline. Okay, I have 10 minutes left, and let's just do this. And then we'll just leave osteoporosis for another time. Let's take a look at calculating the insulin dose. All right, so let's have a diabetic. Let's call our diabetic George. So George is going to eat 60 grams of carbs for lunch. George has an insulin to carb ratio of 1 to 10. 1 to 10. What does that mean? Here's what it means. It means that a unit of insulin will assimilate 10 grams of carbohydrates. So how much insulin does George need to take to be able to assimilate 60 grams of carbohydrates? It's 1 to 10. If 1 to 10 is the same as blank to 60. So it becomes a case of like that. 60 equals 10x, x equals 6. So George will give himself 6 units of insulin in order to assimilate 60 grams of carbs. That make sense? And if you sit down, say, to a meal of 90 carbohydrates, and your insulin to carb ratio is 1 to 15, how much insulin do you need to give yourself? Go ahead and figure it out. Sorry? 6, yeah, 6. 90, and you divide 90 by 15, you get 6. Now, it's not that simple, because you usually have to correct for your present blood glucose reading. So let's have another diabetic. let's call her Jennifer. Jennifer sits down to lunch. Her blood sugar is 220. Her target is 120, so she's 100 mg per deciliter over her target. Her correction factor is going to differ for each patient, is 50. That means that 1 unit of insulin will reduce the blood sugar by 50 mg per deciliter. So how much insulin do you need to assimilate your carbs from lunch? I don't know why it cuts that off like that. Much better. So 100 divided by 50 is 2 units. She needs to give herself 2 units to get herself back to her target blood sugar level. So let's have another diabetic. Let's call this diabetic Manfred. So Manfred has a blood sugar 200. His target is 120. His lunch contains 50 grams of carbs. His insulin to carb ratio is 1 to 10. Correction factor is 40. Now, how much insulin does Manfred need to give himself? So you have to do two calculations here. One for correction, one for lunch. Go ahead and do those. So 200 minus 120 is 80 divided by 40 is, so that's 2 for correction plus 1 to 10, 50 grams of carbs. 50 divided by 10 is 5 plus 2 is, there's your answer. This simply shows you essentially how correction factors get calculated. This is done essentially at the hospital. This is a bit more technical than I want to go into. I'm going to leave that, just we don't have to worry about that. So the exam then will not include osteoporosis. It'll just include diabetes and then the other things we've covered since the last exam, NSAIDs and what have you. Okay, so I will see at least some of you, those of you who come on Tuesday. Don't forget the exam is Wednesday, bright and early, Amanda. Masking makes it impossible to understand that. Say that again. Yep. Thursday at 8:15, yeah.